in general, okay, in very specific ways in the body, but when we get to the drugs and you see how each of them works, there's no one answer for everything. We're just learning some general processes, okay? So in talking about how drugs work, we have to talk about drug action. What does it do to the body, okay? And we often call this the MOA, or the mechanism of action. What's the MOA of that drug? When you guys looked up your drugs, right? It told you what it was for and kind of how it works. Well, it works by, excreting glucose into the blood and then into the urine to get it out of the body. I mean, it tells you basically how it works. What is the mechanism of action, okay? The pharmacokinetics. How does the drug go into the body, get to where it needs to go, exert its action, get out of the body, okay, by being changed by the body and then being excreted, okay? Pharmacokinetics. How does it move through the body? What are the routes of administration? How do drugs get into our body to begin with, okay? And what are the dose forms? Liquid, it's an injection, it's a pill, whatever it might be. And what are some of the things that change how drugs work? Because how a drug works on me might be different than how it works on you, depending on your medical condition, your age, the function of your liver, the function of your kidneys, right? There are lots of variables, okay? And we just need to accept that and then find out how it works for that particular drug on that particular person. So you only have to understand, basically, when you deal with patients, one drug at a time, and then deal with how each of those drugs works with each other and how it works with your patient and how that affects what you do. Okay, so all of these is general, but you're going to deal with specific patients, specific drugs, and you're going to know how to deal with that because of what you're learning. Okay, how drugs work. So why does the dental hygienist, I just do teeth, okay? Why does the dental hygienist need to know about how drugs work? Something's going to be obvious. Like,
some drugs that we might use and the treatment that we choose for our patient might interfere with some medication that the patients are on.
Right. We might be prescribing a drug in the office which interferes or has an interaction with the drug that the patient's already taken. Yes?
The patient could be on something for an allergy.
Patient, okay. Yep, so the patient might have an allergy to something we're using in the office. What else? Yes. They might be on a blood thinner that'll cause their gums to bleed a lot. Okay, so an anticoagulant or an antiplatelet drug. All right? They might be on something like that. And we know dentistry, special hygienists, we make people bleed sometimes, right? Mm-hmm. Or the disease makes them bleed. We're just getting rid of the disease. And sometimes in the process, have a little bit of bleeding. Did you freak out the first time your patient bled? Anyone have a patient with a lot of inflammation where they were bleeding a lot? Maybe. Yes, Brooke.
No.
You did, yeah.
My brother had braces, so it was just all.
Oh, yes, yes. Yeah, you know what? We're going to be, you guys are going to be learning air polishing. And air polishing for someone with braces, awesome. Was there a little plaque around them? A lot, okay. So this stuff kind of blows the plaque off before you even start. Pretty cool, pretty cool. Anyone else? Okay, so you hit some really good ones. You definitely hit some good ones. So we need to discuss drugs just to begin with. So we need to talk to the patient about what they're taking. They're going to come in with the laundry list of what they're taking. And I saw a few people working through laundry lists last week. Okay, and remember we talked about if you can looking up drugs ahead of time, you give yourself a little bit of a head start. So we need to talk to our patients about what they're taking, to begin with. And what are the possible effects that we can see that it might have on the patient? Does it cause? Did anybody run into this with their drug? Orthostatic hypotension just means when you move suddenly, you might pass out. Okay, it might make your blood pressure drop. Okay, so if we have an elderly person on 3 drugs that cause orthostatic hypotension, are we going to say, hey, I'll be right back. If you need to go to the restroom, just go ahead and you run off to get your fluoride? Yeah, no. Okay, we're going to make sure that we sit them up slowly, that they can get out of the chair. So what problems can they cause within the dental visit, and what problems can they cause in general? Okay, how is that going to affect how I treat my patient? Maybe they're going to bleed. Okay, maybe we're going to recommend something they might have an allergy to. Okay, patient communication. They need to trust you. Did you feel like all of a sudden last week this person is putting their trust in me and I have no idea what I'm doing? Right? All right, maybe a little bit. You know, it's not that you had no idea, but you know, but there's that person, and they're looking at you like they trust you, even though it's your brother, and they don't think you know what you're doing, or your mom, and she wants you to know what you're doing, you know, whatever it might be. But you're communicating with your patient. They need to basically trust you, okay? And you know, there's that term like fake it to make it, but I have another one that's a little more positive. It's like act as if you know what you're doing, and you do. You know a whole lot more than they do. Okay, unless your dad's a dentist and he's your patient, and oh, Val just come in. Oh, that's happened before. Is he coming in as your patient?
No.
Oh, she's like, no, that's not happening. All right. We know we talked about last week that drugs that were discovered by kind of randomly, you know, searching through plants and minerals and all kinds of things, and then testing them out to see if they have an effect on the body. Maybe someone was hungry and they ate a leaf of something, and all of a sudden their heart started to race. Okay, and they thought, ooh, this has an effect on my heart. Okay, we know that medicine men and shamans and different people within tribes discovered how they worked a long time ago, and it was kind of variable. Well, let's just try a little tea of 3 leaves and kind of see what happens. Oh, that was too much. Let's try 2 leaves. Well, now we have organic and synthetic chemistry where we can take an extract of that leaf and figure out which part of it affects our heart or our body, right? And we can control how much we give and how often we give it so we have a more predictable reaction to it, right? That's modern pharmacology, all right? We systematically then study it on a group of people like we talked about. First we test on tissues and animals, and then we go with a small group of people and a larger group of people, and we collect data and information. Is it safe? Does it work? How much should we give to have this kind of effect? What are some of the adverse effects? So they're very systematically and controlled now, okay? So we kind of know, we sometimes get surprised, but we kind of know how it works. People are prescribed medication, and then they're told, well, it's going to do this for you, which is great, but then it also might do this, 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 and this, right? And we know those ahead of time. So in order to examine how a drug works, we have a number of different ways of characterizing the response to remember it, okay, and to use it therapeutically. The log dose effect, remember that curve, we're going to talk about that a lot more, as you know. The potency and the efficacy, how many are confused by potency and efficacy? A little bit, okay? You're going to get it right though, okay? You're going to get it right. And the therapeutic index, right, that margin of safety between where the drug works and then where it might have an adverse effect, okay? A minor adverse effect or a major adverse effect, all right? So there's that log dose response, okay, or dose response curve, okay? And it's the concentration of drug on the x-axis, okay, as well as then the response on the y-axis, okay? So the concentration versus the response, okay? And the response could be a good response and it could be a poor response. It could be a negative response. How does it affect, where do we get to the point where we can see it in our blood level? How does it affect other hormones in the body? How does it affect the blood pressure, okay? All of those different things. Any response whatsoever, good, bad, or indifferent, okay? So we know in general that when you give a drug, it starts to rise and you start getting more of it and you get into the place where it starts to have a therapeutic effect, right? And then it levels off. And no matter how much more you give, right, it might not have any more of that effect that you're looking for. It might have other effects, okay? So it might not any longer be modulating your pain. Your pain leveled off at one point. That's all the pain amelioration that's going to happen. That's all the pain that's going to go away. But in the meanwhile, it shut down your respiratory system, okay? So it might have more adverse effects, but for that particular effect you're measuring, it levels off at one point, okay? All right, reaches the maximum effect. So the log dose curve looks a little different, doesn't it? Because generally when you get a drug, there's a level area there, right? It doesn't start to have an effect till it gets to a certain level. And then we start to get that rise and we start to get that therapeutic effect. And remember when they study it, when half of the experimental animals have an effective response, right? We get that LD50, right? Right there, 50%, the ED50, the effective dose 50, right? And this is also how we can measure then how effective is it and how potent is it? How potent is it, all right? We can determine that by looking at this log dose curve. So let's start with potency, okay? Potency is defined, and you should just know this definition. It's a function of the amount of drug necessary to produce an effect, all right? The amount of drug necessary, okay? It's shown, okay, by putting it along with the log dose curve, okay? Along the x-axis, we see the amount, the log dose. Log stands for logarithm, okay? Increments, little amounts. And the intensity of the response is measured by the height of the curve, okay? So we have two drugs here. We have drug A and drug B, all right? And this is the amount, so are we giving more or less of this drug?
Less.
We're giving less of this drug, we're giving more of drug B, okay? We give less of this drug, okay? We give more of this drug, okay? But if the drug we're giving here has the same height of response, okay, which drug is more potent? A. We gave less of it, and it had the same response as more of the other, okay? Make it easier to understand. Yes, that is alcohol, because you won't forget this, okay? So 1 ounce of very strong whiskey, okay, 12 ounces of beer, or 16 ounces of a wine spritzer, okay, can make you equally drunk. All right, to the same level. It has the same potency, okay? Has the same effect on you. But it has different potencies because it takes a smaller amount of one to make you just as drunk as the big amount of the other. It helps to remember. You're going to remember this, okay? I try to think, what will people remember? This is what they'll remember, okay?
Drunk, I'm gonna think of.
Well, okay, well, don't even, no. Not even. All right, but, right? Okay, so you are the same amount, same effect on your body, where you shouldn't drive, or whatever it might be, or you just feel a little relaxed, okay? Same effect, but a small amount of one, a medium amount of the other. They all have the same potency, okay, giving you that effect. Okay, another example. This is in your book, and it's a good one. How many of you have heard of morphine? Okay, how about meperidine? Not so much, right? Okay. Morphine and meperidine are both used for severe pain. Okay, so pain associated with different conditions and diseases, cancer pain, intractable pain, okay, really bad pain. And we hear about people having morphine, you know, either when they've had surgery or end-of-life things, that kind of thing. Okay, morphine is an extremely efficient, extremely potent drug reliever. Okay, pain reliever. Analgesic, same thing, okay? Meperidine can have the same effect, okay? But you have to give 10 times as much meperidine to get the same effect as you do the morphine. Yes?
Why would they use that? Like, in what situations would they?
Would they use meperidine?
Yeah.
Well, when you look at the side effects of it, yeah. Yeah, when you look at the side effects of it, one might be better than the other. Yeah. There's a lot. Yes, question.
If they're both doing the same thing, would they have the same drug interactions, or would they be able to?
Not necessarily.
No, okay.
So that might be the reason why you choose one over the other.
Okay.
Okay. We also know that morphine is, you know, we talked about that when you get to the first pass effect, has a really high first pass effect. So it depends on how you use it there. But just accept that they will have the same, okay, same effect here, but they have different potencies. You have to give 10 times as much as one as the other, okay?
So you would need to give, like, if you wanted it to react within the same amount of time, you'd have to give a larger amount of
The meperidine, yes, yes. And it doesn't have to be the same amount of time, it just has to have the same effect, okay? This is effect up here, okay? This is potency. So the further towards the y-axis we are, the more potent the drug that has the same effect, okay? All right. Got it? They get to the same effect, you just need more of one than the other. Okay. Efficacy, all right? The maximal intensity of effect or response that can be produced by a drug. No matter how much more you give, right? In this case, this second drug is not going to ever have the same efficacy as the other drug. Never, okay? So let's call the drug on the left, okay, which has more efficacy, we'll call that morphine. Let's call the drug on the right acetaminophen, Tylenol. No matter how much Tylenol you give, it's not going to relieve pain as effectively as morphine. They have two different efficacies, okay? Just by giving more, you're never going to have the same effect. What do we know about Tylenol? You can give more and more and more and more and more and more, okay? And again, you might die from your liver shutting down, but you're never going to get the same pain relief as you're going to get from morphine, okay? Efficacy increases as the height of the curve increases, okay? Maximal intensity is its efficacy, okay? But remember, if you give more trying to get that same effect, and people do that, right? They take more and more thinking it's going to get rid of that headache finally, and it just never does. It doesn't work. For anyone that suffers from really bad headaches, they know there's a certain medication that's going to relieve it for them, and other ones are just not going to cut it, right? But you're going to increase your probability of an adverse reaction.
I have a question.
Yep.
Now, could that be different based on the person's pain?
Individual responses to drugs is very variable. Yes, it could be. So what works for one person might work well enough for them and not for another person. Yes, yes. Individual tolerances, individual metabolisms all have a different effect. But in generally speaking, in any given person, morphine is going to work to relieve severe pain better than Tylenol. Okay, that's just true. Okay, we know that through experience. And we also look at what works that way on the most people. Everyone has individual idiosyncrasies, right? Different responses, but in general, that's not true, okay? So drugs may be equally efficacious, okay? Remember, morphine and meperidine, equally effective, equally efficacious, okay? But they differ in their potency. So the efficacy and the potency of a drug are unrelated. Just remember that, okay? They're not related. They're different aspects of it, yes.
Would it be kind of like comparing quality versus quantity? Like potency would be how much you need for an effect, and efficacy would be how effective or quality.
You can think
the
of it
drug
that
is.
way. I think of it that way. That's a good way to remember it. That's a good way to remember it. It might not work for everybody, but I think that's a pretty neat aspect of it. Yes. Yes.
Can amount of potency affect the body differently? Like if you're doing 10 milligrams of one and 100 milligrams, that's like a big difference, but it's doing the same effect. So does it affect it?
You may, I know where you're going. You're thinking, well, why don't just not take 10 milligrams of one because you're going to get, it really depends on the individual drug. And remember we talked about morphine having some adverse effects that maybe meperidine doesn't have. So the pain relief might be because of the way it affects the central nervous system, okay? Whereas the other one might be more anti-inflammatory. So, I mean, there's so many qualities in there that may affect why you give one drug over another, including what else the person's taking. Yeah, so your decision as to what drug to give is, yes, going to depend on the level of pain, but it's also going to depend on, you know, maybe the other one makes you dizzy and that person has to drive, okay, for a living, okay, or fly a plane or something, okay? So, good question. It's a good question. But just in terms of comparing one to the other, one's more potent than the other. Really good question. Okay, remember the therapeutic index, just to go over it again with you, okay? We compare the median lethal dose and the median effective dose. Median lethal dose kills half the animals. Median effective dose is where you get that specific effect you're looking for in half of the experimental animals, okay? And if you divide the effective dose into the lethal dose, you're going to get that TI, that therapeutic index, okay? So when they evaluate the toxicology, how toxic is this drug in one way or another, think toxic, think adverse effects, okay? You want it to be as wide as possible. Now this curve shows you the therapeutic effect, so where it's relieving pain or whatever it needs to do. And there's adverse reaction 1 and adverse reaction 2. Adverse reaction 1 might be drowsiness. Adverse reaction 2 is death. Okay? So you're willing to get a little drowsy to relieve your pain, right? You might be willing to get a little drowsy because you just had surgery and you're staying home with your feet up, okay? So you might be willing to be a little bit drowsy, but you don't want to die, okay? So we want to make sure that that space, that our dose is correct, okay? And there are drugs that do this, okay? Opioid crisis, can we hear this, right? People take more drug to get the same effect, and you know, we'll get into that in a bit. But, so you might be willing to be sleepy, but you don't want to die. So you have to keep that dose, the amount that you're taking and the time in between your dosages, you want to keep it in a safe zone so you don't build up a blood level that becomes toxic, okay, to that effect. This is a toxic effect, this is a toxic effect. One's okay, one's not so okay.